Greetings and welcome. I am so excited to be with you and to be with three of the global experts in ovarian cancer. I'm joined today by Alex Holloway, McGee's Women's Hospital of the University of Pittsburgh Medical Center. Alex, nice to see you today. Also by Professor Keta LaRusso from Humanitas University in Milano, and David O'Malley from the Ohio State University in Columbus, Ohio. So welcome, friends. We just heard some news. GOG-3073, OV72, no way, a positive trial in platinum-resistant recurrent ovarian cancer. And you guys, when I say you guys, I mean the listeners did it again. So let's get going here. Keta, tell us about the relationship with ENGOT and the GOG and what sort of trials we do together.
It is a very great and I would say successful collaboration. We work together since several years, and without this collaboration, probably a lot of trials that had completely changed the treatment landscape. Not only in ovarian cancer, I have to say, but in all gynecological malignancies could be impossible. You know, gynecological cancer are rare tumors, and we decided several years ago that in order to change the treatment and life of our patients, we have to work together across the ocean, because only if we work together, we can produce evidence that can change and impact the treatment. And we are doing that. We are doing that, and we are doing that since several years in all the malignancies, phase 1 ovarian, frontline ovarian cancer, recurrent endometrial cancer, cervical cancer, and now we are celebrating another success of our collaboration.
That's great. So Dave, under your guidance, the GOG does basically two types of trials. A +1 design, so they add to effective therapy versus a head-to-head comparison. Compare and contrast those. Why do we do those different types of trials, and what was ROSELLA?
Well, really, when you look at relacorilant in ROSELLA, when we looked at the original data, it by itself did not have tumor regression. Okay. And so we really think, we'll talk more about it, it actually potentially changes the response rate to the chemotherapy. Now, is that true for all? No. I had the honor to lead the GOG for the tumor treating fields. By itself, these agents are not shrinking tumors. So in that case, we add it on and then compare to the historical control, like weekly taxanes with relacorilant. So that is the +1. When we go to head, when we say like MERV and Mirasol versus the standard chemotherapy, we're going 1 versus 1, seeing if the new therapies are better and potentially safer than the historicals.
Yeah, that's well said. And there are lots of examples. So just look at IO and PMMR endometrial cancer, right? Just look at, bevacizumab in ovarian and cervical. So those are +1 designs. This is exciting. So Alex, congratulations. You're the global PI. You've worked very closely with Keta to get this thing done. We can't wait to see the data presented. What sort of endpoints are relevant in these sorts of randomized phase 3 trials?
Thank you, Brad. This is a very good question. Progression-free survival when the crossover and post-progression are long. And that is important because when overall survival is less than 12 to 18 months, we have to focus on progression-free survival. And that is exactly what is done in most of our clinical trials, because of the crossover that tends to dominate those trials.
So smart, and thank you for that. So again, like in a frontline PARP trial where crossover happens and post-progression survival is long, PFS is the endpoint. But in your guys' wonderful trial, because survival is short and no one's going to cross over to relacorilant, overall survival is among the most important endpoints. Now, Keta, tell us about the mechanism of action of this medication we keep calling relacorilant. Some of our listeners may not be familiar with it.
Yes, it is a very interesting new pathway preliminary in solid tumor. Relacorilant is a selective glucocorticoid receptor inhibitor. We have to know that even in a physiological condition, the cortisol level in our body can suppress immune activation and tumor apoptosis. And we know that when the glucocorticoid receptor is activated, there is a push with respect to tumor progression through a mechanism that we call epithelial mesenchymal translation, and also there is the induction of chemotherapy resistance. So the idea was, if we block this receptor, probably we can enhance sensitivity to chemotherapy. And this is in such a way what we did in a preliminary randomized phase 2 trial in which we combine relacorilant with nab-paclitaxel. Why nab-paclitaxel? Because the mechanism of action of relacorilant is based on the glucocorticoid receptor. So this drug, it's difficult to combine with the chemotherapy that requests high amount of glucocorticosteroid premedication. And nab-paclitaxel was perfect from this point of view. And in addition, we have data suggesting activity of nab-paclitaxel, weekly nab-paclitaxel in ovarian cancer. So for all these reasons, this combo seems to be very interesting in the randomized phase 2 trial, and we demonstrate a significant benefit in progression-free survival when combining relacorilant with nab-paclitaxel, and the trend also in overall survival. And this represents the backbone to build on the randomized phase 3.
Now, wait a minute. So you did a phase 2 trial before a phase 3 trial? Dave, isn't that what you always do?
Yeah, we're not as much as we used to, right? We used to have the phase 1, then we have the phase 2. Now, and again, some of the timeliness in getting these, getting our active drugs to our patients more quickly. But we have made decisions again based on clinical data, looking at other solid tumors, which we kind of skipped that phase 2 step, and this is really a testament that getting that data, getting that confidence. So you're doing a phase 3 trial at a phase 3 risk, not at a phase 1/2 risk.
There you
right?
go.
So you're more confident with regards to now saying that we never know what the results are going to be. But I'd like to go back to one thing very, very important that Ket has said. This is a completely new mechanism of action. And Brad, I'm not the smartest guy, right? And I'm
Yes,
like,
you are.
mechanism of action, like just tell me, does it work? And is it safe? But this is different because I'm like, wait a second, you're telling me that an antagonizing of the effects of the cortisol at the glucocorticoid receptor. So even at physiologic doses that cortisol goes up, what do we know about cortisol? It suppresses the body's immune response, right? It potentially changes at the cellular level. And what we're doing then is this agent is antagonizing that is antagonizing the effects of the cortisol at the receptor, at the glucocorticoid receptor. Very, very different. And more data being generated, the importance of steroids, as well as potentially hormones in ovarian cancer. So we're going to hear more and more about that in the future. Very important, the unique mechanism here.
Fascinating. And personally, I have a little PARP exhaustion, and I'm starting to get ADC exhausted. So I'm energized here. So Alex, tell us about your study, our study, the listener study. Tell us what the design is. We don't know a lot, but we do have a press release. Tell us about what the design was and what the top level press release said.
Thank you, Brad. This is an open label trial with the endpoint being based on blinded investigator central review. Where we recruited 381 patients or subjects to this trial, noble women who helped us to perform the trial. The control arm of the trial is nab-paclitaxel alone, and the experimental arm is nab-paclitaxel combined with this new agent called relacorilant.
Yeah, so randomized phase 3 trial, +1 design, Dave, ENGOT GOG collaboration, KETA, and what did it show in the press release, Alex?
We reported the preliminary data that will be presented in the future, obviously in a more complete way, but the press release anticipates that we get the primary endpoint of the trial, the two primary endpoints of the trial, and there is a significant increase in progression-free survival with another ratio of 0.7 that transforms in an increase in 1 month PFS, but much more important, there is a significant increase in overall survival with another ratio of 0.69 that transforms in 4.5 increase in median overall survival. And what is important here is that, as has been said, the comparison here is in 1+ design. We have only one comparator arm in the control arm, that is a weekly taxane, which is one of the drugs that we consider most active.
Yeah, that's incredible. So rather than beat the worst medication, like just saying topotecan or liposomal doxorubicin, Alex, you added to the best. That is absolutely sensational. Tell us about the safety. Were there any safety signals, Alex?
There were no safety signals. The safety profile that we saw in the phase 3 clinical trial is very similar to what we saw in the phase 2 trial preceding it. So there were no new safety signals.
And it's a very tolerable agent, right, Alex?
It is a very tolerable agent.
Oral.
It was very easy. It is very easy to give, and we had no problems with it in the phase 2 trial, and we have had no problem with it thus far in the phase 3 trial.
So oral, intermittent dosing, right?
Yep.
Intermittent, we showed that that was the benefit in the phase 2, and that's probably trials positive, right? We figured out the dosing, so dose optimization, right, Brad? Dose optimization, right? You know, and the intermittent, which was really key, which showed an improvement in the phase 2, and that's what was moved forward. So really, really amazing, and congratulations to you both for your leadership, not on just this trial, but many trials across the world. But, you know, so many important things. And Brad, to your point, and I'm sorry for interjecting, I'm just so excited, obviously.
I'm fired up, right?
We've done lots, and there's many reasons we design trials like this, but working with the FDA and coming up with the EMA, having just one agent in the control arm, particularly with nab-paclitaxel, which is not one of the three, though we call it weekly taxane, it's, you know, we weren't sure. And the performance of the control arm is exactly where we'd expect it for weekly paclitaxel. Exactly. So it's not the underperformance of the control arm that showed this benefit, right? We only have one agent in the control arm, weekly taxane. We have absolutely the performance of the control arm we would expect on a weekly taxane. And obviously we have to see the data, right? But this is with the limited information we have in the press release, really consistent with what we expect with weekly taxanes.
So Alex, what's the next plan? My good friend, brother, and colleague. What's next?
Well, with this excitement, we are hopeful that this new agent, based on what it has demonstrated in this large phase 3 trial, can be taken into earlier lines.
Okay.
We can look at it with other combinations and so on and so forth. There are a lot of opportunities here, and GOG is going to be, of course, collaborating with the sponsor and ENGOT as usual to see where else we can take this new exciting agent.
Thank you.
Well, Alex, you're going to show us the data, though, at some point, right?
What's next?
You got to be a little bit more data here, man.
That's right. What's next? Put what you guys at the podium. So we're excited about that. So KETA, what sort of combinations, and then we'll wrap this thing up. What sort of combinations would be interesting?
Brad, this is an exciting combo. I think this has the possibility to be a key treatment for our platinum-resistant patients. But you know that in this setting, we have also bevacizumab.
Okay.
So the missing point in this combo is the absence of bevacizumab. But we are working on that. There is a phase 2 trial ongoing again from the collaboration of GOG and ENGOT, which is the BELLA trial. That is a single-arm phase 2 trial combining relacorilant plus nab-paclitaxel plus bevacizumab to answer the missing question about the rule of Bev in this combo.
That's brilliant. So congratulations to patients. That's why we get up in the morning. Congratulations to you who did the work. These are our leaders. Thank you for your vision. Dave, I'm going to give you the last word here as we wrap things up. And again, probably you, Alex, as the global PI, we look forward to seeing you at the podium. Go ahead, Dave. Last word.
Thank you.
I just want to congratulate Ken and Alex and really all the GOG and ENGOT and the collaborators across the world. You know, part of the GOG, we also collaborate with our Latin American colleagues, our Canadian colleagues in the Far East, our Korean colleagues. So, you know, when we really see this is a worldwide trial. And why is it? It's because of we enrolled it, I think, just about a year. And it was because the commitment of the investigators, hopefully listening to this, that show how important enrollment in clinical trials are. And we are not going to improve the care of patients with GYN cancers unless we do well-designed clinical trials like this one. So thank you to all of you for having that commitment, for having that passion to help our patients and to improve the care of patients with GYN cancer.
Thank you, everyone. And so long for now and more to come.